Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Last month on the podcast, we talked about updates in the diagnosis of autoimmune encephalitis. This month, we turn to advances in treating autoimmune encephalitis. Treating these conditions has traditionally been practitioner-dependent, and currently no FDA-approved therapies exist, but that's beginning to change. Our guest today is Dr. Maarten Titulaer, neuroimmunologist in the Department of Neurology at Erasmus MC University Medical Center in the Netherlands. He is an expert in autoimmune encephalitis and recently co-authored a set of expert guidelines on the treatment of these conditions. Dr. Titulaer was interviewed by ANA producer and neuroimmunologist Dr. Rohini Samudralwar of the University of Texas Health Science Center at Houston. Here's Rohini.
Welcome, Maarten. Thank you so much for joining us on ANA Investigates. We are excited to get into the advances in treatment and management for autoimmune encephalitis and paraneoplastic disease.
Thank you. It's a pleasure to be invited.
Great. Let's get started. The acute treatment of autoimmune encephalitis usually starts with a combination of steroids followed by IVIG or plasma exchange. But that's when things get challenging for providers because they have to decide whether or not to add a steroid-sparing agent that offers long-term disease control, like B-cell therapy agents. I wonder if we can start by discussing escalation or maintenance therapy. What has been used and why?
I think we can distinguish several types of treatments, and this is mostly differed from anti-NMDA receptor encephalitis, for which we have most data. Generally, the initial treatments that are provided if patients do not respond to the first-line immunotherapies, and generally you know by 2 weeks, maybe max 3 weeks after the initiation of the first-line immunotherapy, whether or not your patient will or will not respond quickly. You can add often rituximab, and there's also quite some evidence for cyclophosphamide. Generally, rituximab is favored by many because of the relative limited amount of side effects, the ease of use, and cyclophosphamide has a rather bad reputation, mainly based on very old data from over 50 years ago, when it was administered in a very different and very more aggressive and dangerous way. In a lot of ways, it's not that bad to administer, especially if you keep the amount you provide in the end to a limited dose. But generally said, if patients do not respond or you don't see any response, you would add rituximab and or cyclophosphamide. And in severe cases of anti-NMDA receptor encephalitis, we tend to provide both of them. The escalation therapy for other types of autoimmune encephalitis is a little bit less known. There are no large series. There is some evidence from the German data registry that rituximab and IGLON-5 can have its advantages. Probably it works for the other cell surface antigens like LGR1 and Caspar-2 as well, but there's only limited data at this moment.
So how would one go about deciding whether a patient with autoimmune encephalitis needs long-term maintenance therapy? And how long does maintenance therapy need to continue? Is it purely dependent on the antibody itself?
No, that's a very relevant question, and a question that we actually discuss with our patients every week. Maintenance therapy is a little bit a different area, because the main reason is not the ongoing inflammation, as in some other diseases, but it's mainly to avoid relapse risks. And it very much depends per antibody how large your relapse risk is. For example, in anti-NMDA receptor encephalitis, the relapse risk is about 12, maybe 15% in the overall, but it's been proven that after rituximab, at least within the first years, the relapse risk drops down to only a few percent. Whether this is also true for the other autoimmune encephalitis types, we don't know at this moment, But the limited amount of cohort studies we have seem to suggest that in those rituximab reduces the relapse risk as well. What is important is that the current studies that have been described, the cohorts, only used rituximab during the acute phase or directly after the acute phase to avoid new relapses. And although a lot of people seem to consider rituximab to be used for years afterwards, there's not a single shred of evidence that suggests that it's relevant to repeat rituximab in autoimmune encephalitis unless there are specific additional circumstances like relapsing after reoccurrence of B cells. The idea of repeating rituximab is directly deferred from NMO spectrum disorder, which is a completely different disease with a far higher relapse risk and a far more aggressive relapse type. I don't think there's any evidence at this moment to suggest steroid-sparing agents in diseases like anti-NMDA receptor encephalitis. If we look at some of the other autoimmune encephalitis, like LGR1 or Casper2, where the relapse risk is about 1/3, we tend to treat them by long-term steroid-sparing agents like azathioprine or mycophenolate, or sometimes also rituximab.
And what about newer immunotherapies? Are there targets that we should be aware of?
Two treatments that have been described in at least smaller, very small to smaller cohorts are tocilizumab and bortezomib. So tocilizumab is an IL-6 receptor blocker, and bortezomib is a proteasome inhibitor, the last one attacking the plasma cells, and therefore getting rid of the antibodies in a maybe more direct way than rituximab. The current data are insufficient to position it among the other B-cell depletion therapies like rituximab, but these are potentially interesting targets to use.
I wanted to switch gears a little bit. We mentioned these neuronal cell surface antigens like NMDA, LGI1, or Casper2. However, patients with antibodies targeting intracellular epitopes such as paraneoplastic syndromes have less established therapies and often have worse prognosis. When we identify these intracellular antigens, what's the best approach to treatment?
Yeah, that's difficult. Generally, the treatment is quite disappointing, very different from the extracellular targets. The most important thing is the identification of the tumor. And once you identify it, remove it or treat it as quickly as you can. And this sometimes is not that easy because the tumor lesions are generally smaller in paraneoplastic cases than in the regular oncology practice. So it might, for lung cancer, it might only be a mediastinal gland. You do not see a parenchymal lung lesion. That's one thing. And the other item is the Karnofsky performance scale. As they say, well, we don't want to use chemotherapy because the patient is not doing well enough due to the neurological condition. But this is a catch-22, because if you don't treat them, the patient will never improve. And only if you treat the tumor, the trigger is gone, you can actually try to get rid of this paraneoplastic immune response and therefore have your patient improve or stabilize. Another item is, even though you have a paraneoplastic disorder, and even though you might have an intracellular antigen you have an antibody against, they might have two antibodies as well. So for example, in a patient with HU, they can have additionally GABA B receptor antibodies. And in those patients, the level of improvement is better than if you only have HU antibodies. However, the large majority, they have only intracellular targets, and in those, there's basically no proven treatment. There's expert opinion consensus that it is useful to use by steroids and IVIG or steroids and plasma exchange at least once to give it a try. Probably rituximab is not that very sensible to treat, although people might try. Cyclophosphamide might be a more relevant treatment because it also targets T cells, and we think that the antibody is actually more like a biomarker for a T cell mediated cytotoxic disease, and therefore a more broad immunotherapy, for example, including cyclophosphamide, might be a more sensible way to do. Based on this idea of the not only B cells but also T cells, leukocytes entering the brain, there has been enthusiasm about natalizumab in paraneoplastic disorders, and only last year a open-label trial of natalizumab in anti-HU has been published by Bastians et al. Unfortunately, it didn't show a better outcome compared to historic other studies in anti-HU, so it didn't seem to have a major effect. But yeah, unfortunately, stabilization might be the best we can achieve. So therefore, early diagnosis and early treatment is the most important item.
Definitely continuing to be a major challenge in the field, but one exciting step forward is the introduction this year of the ExTinguish trial of inebilizumab in NMDA encephalitis. Can you tell us more about this trial?
Yes, of course. I'm very excited about this trial as well, as we've been working on the design for several years, and we're very happy that it is approved as a Neuronext trial funded by the NIH and NINDS. It's a study that will run in 20 US sites and additionally in 2 European sites, Barcelona and Rotterdam. It will study the use of inebilizumab versus placebo in addition to first-line immunotherapy, meaning steroids and IVIG, or steroids and plasma exchange IV. And inebilizumab is an anti-CD19 monoclonal antibody, thereby targeting B cells, but also pro-B cells and plasmablasts. So it has a little bit wider range of antibody-producing cells and antibody pre-producing cells that it targets then anti-CD20 therapy, and thereby theoretically it might act quicker and maybe also better, but that we don't know. We will include patients that have a severe anti-NMDA receptor encephalitis despite treatment with first-line immunotherapy. So patients are pre-screened during their first-line immunotherapy, and if they do not respond almost immediately, then they will be eligible to enter the study and receive inebilizumab or placebo at day 1 and day 15. And this is a long-acting medication, so you don't have to redose. But we will have an additional round of IVIG after 3 weeks and at 6 weeks, because some of these patients might be very ill and still at the ICU. So patients will be allocated at 16 weeks, but also at 24 weeks, looking at the change in MRS, but also at different other outcome scores cognitively, the case score, and they have an extended follow-up up till max of 96 weeks.
Well, we look forward to seeing the results of this trial and perhaps see an FDA-approved therapy for NMDA encephalitis in the future, and maybe even a pathway to an outcome scoring specific to this disease. There are several other novel immunological targets, such as neonatal FC receptor and complement cascade, that may or may not have relevance in autoimmune encephalitis. Some have been validated in other neuroimmunological conditions. Can you speak on their place in autoimmune encephalitis?
Yeah, the FcRn treatments have been trialed in myasthenia gravis and have shown good results. And there is a currently recruiting study in the autoimmune encephalitis as well. In anti-LGR1 encephalitis, the Legione study, and it is expected to be quite effective, I think. And I think if it will work, it probably will have its position relatively early in disease or maybe early escalation. Whether it's also useful in the continued treatment, we don't know yet, although from myasthenia, we do know that patients tend to relapse once you stop these treatments. So you have to switch to alternative treatments to avoid new relapses if they have been effective. Complement cascade is another topic which has been the trial in NMOSD, but also in myasthenia and in Guillain-Barré syndrome have all been successful. However, it's not so clear whether this is also true for autoimmune encephalitis, as far as there's not so much evidence that complement plays a very large role in the majority of patients with these antibodies. Generally, the antibodies have a functional effect, and relatively the additional cytotoxic effect and the additional complement activating effects are much less pronounced compared to diseases like Guillain-Barré or NMOSD. And part of it might be due to some of the antibodies being of the IgG4 subclass, like LGA1, Caspar-2, but also IGLON5. And we know that the capacity to activate complement is much, much lower in IgG4 compared to IgG1. So I'm not sure. There might be a place for complement cascade, but I think there is currently insufficient evidence that it actually has a position.
That's so helpful to distinguish different immune targets and how they vary between diseases. Looking ahead, what is next in the field of autoimmune encephalitis and paraneoplastic disease?
Basically, there's more than we simply can investigate. There are so many targets that we could trial, but I think trials will also provide a huge amount of standardized prospective data. That's very important as well. And it might be difficult to run trials. It's not that easy to perform a trial in rare diseases, and generally, especially if they are severe, physicians are reluctant to enter them into trials because of the risk of they are afraid that they will undertreat the patient. So a placebo arm is a risk. And so we also need to consider other ways to compare treatments, for example, by sophisticated prospective comparative analysis between cohorts. Also, it will be important to have better outcome measures so that we can get rid of the MRS, that we actually capture improvement in patients that's relevant for patients, that's relevant for the disease mechanism, relevant to clinicians, and also shows enough change to actually measure it over time within the short term, but also in the long term. Additionally, there will be development of biomarkers that are able to make a choice. Like if we get more treatment options, it might be relevant to know, okay, if you have this type of immune pathways, these are more active, these are less active, then this treatment might be more relevant for you, while in the other, it might be more relevant to use drug B. So there's a lot of challenges, but also a lot of opportunities to really get the outcomes of patients much better, to capture it better and treat them better.
Definitely so many things to look forward to and avenues to explore and diagnosis, prognosis, and trial design, like you mentioned. Thank you so much for joining us today and wrapping up our series on autoimmune encephalitis and paraneoplastic disease.
Thank you. It was a pleasure.
That was Dr. Maarten Titulaer, neuroimmunologist in the Department of Neurology at Erasmus MC University Medical Center in the Netherlands, interviewed by Dr. Rohini Samudralwar of the University of Texas Health Science Center at Houston. Thanks for joining us on ANA Investigates. To listen to past episodes or to suggest an idea for a future podcast, you can visit our website, myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Dr. Megan Ritchie. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.